Okay, I think we go ahead and get started. Good afternoon, everyone. Welcome to the NCS Journal Club. My name is Mohammed Effendi, and I'm a neurocritical care pharmacist at Capitol Health Regional Medical Center. I'll be serving as a moderator today for today's Journal Club presentation. We also have two other co-moderators who will be helping out. Kristen Sloan. She is a neurocritical care pharmacist at Zuckerberg San Francisco General Hospital and Trauma Center, as well as Karen Berger. She is a neurocritical care pharmacist at Nova Southeastern University Hospital. If you have a Twitter, please follow along on Twitter using the hashtag NCSPharmJC. You can see it on the slide that's presented right now, and I'll put it in the chat as well in case you forget. You'll have that available. It's a great way to have discussions, questions, and debate the different topics at hand today. Some housekeeping notes. Please keep yourself mute during the presentation. Both of the presentations that we have today are going to be approximately 25 minutes, followed by approximately 5 minutes of questions after completion of a presentation. You can ask questions either via the chat, or you can unmute yourself during the period in which we're asking questions and then ask the question out loud. Just remember to remute yourself after you ask the question. So our first speaker is Jessica Danielle. Jessica is a PGY2 critical care resident at Yale New Haven Hospital. Her journal article is going to be on venous thromboembolism prophylaxis after neurosurgical intervention for traumatic brain injury. Okay, I'm going to stop the share and let you screen share now.
Oops, I'm sorry, I clicked the wrong one. Okay. Do you see it okay?
Yep, that's perfect.
All right, perfect. All right, thank you for the introduction. So I'm going to be presenting today on venous thromboembolism prophylaxis after neurosurgical intervention for traumatic brain injury. So to start, at the conclusion of this presentation, you all should be able to identify current recommendations for venous thromboembolism prophylaxis in patients with a traumatic brain injury. Just as a note, you'll see venous thromboembolism as VTE and traumatic brain injury abbreviated as TBI throughout the remainder of this presentation. You'll also be able to assess the utilization of VTE chemical prophylaxis in patients who are requiring neurosurgical intervention. So I want to provide some background on this patient population that I'm going to be presenting today. So patients who have a TBI are at an increased risk of developing VTE. As you may all recall, Virchow's triad is here on the right side of the slide, and it demonstrates these three categories that put patients at an increased risk of developing thrombosis. Patients who have a TBI are at risk of each of the three components of Virchow's triad. So I'll go through each one of the three. Patients who have a TBI may have some component of endothelial injury, maybe due to the nature of their TBI, such as the direct injury due to the trauma to the endothelium. Patients may also be in a hypercoagulable state after having some sort of trauma occur. And then also patients who've experienced a severe trauma may not be able to mobilize while on the unit. Patients with a severe trauma may not be able to mobilize on the units, which may lead to a stasis of their blood flow. So as you can see, that patients with a TBI will have some degree of each of these three components of Virchow's triad, which will put them at an increased risk of developing a VTE. And it's also been estimated in the literature that a patient's risk of deep vein thrombosis, or DVT, will also increase as the severity of TBI increases. And that kind of makes sense when we're considering each of these three components of Virchow's triad. It's also been estimated that about 1/3 of patients with a moderate to severe TBI may develop DVT. And so you can see that it's important to determine when it is both safe and necessary to begin mechanical and chemical VTE prophylaxis in patients with TBI due to these increased risk factors. So TBIs can be categorized as either mild, moderate to severe, and the easiest way to determine between the severity of TBI is by utilizing the Glasgow Coma Scale, or GCS. So I put this on the left side of the screen, but basically this scale helps us determine the severity of coma from 3 to 15, and it incorporates different components such as the patient's ability to open their eyes, their verbal response, if any, and motor response, if any. And then the nurse or practitioner will add up the score to help determine the severity of TBI. So a mild TBI is defined as a GCS between 13 and 15, moderate TBI, GCS between 9 and 12, and severe TBI between 3 and 8. So we're going to be focusing on severe TBI throughout the remainder of this presentation. So I want to give a little bit of background on some of the literature that came out prior to the study that I'm going to present today about the safety and efficacy of VTE prophylaxis in TBI patients in general. So Scuddy and colleagues designed a retrospective observational study that assessed the early use of pharmacologic prophylaxis and whether it reduced the incidence of VTE without expansion of intracranial hemorrhage in patients with TBI. At this author's institution, they had a policy in place that allowed for initiation of chemical prophylaxis after there was a repeated CT scan that showed no progression of the initial injury. So patients were divided into groups, including those who received VTE prophylaxis or patients who received no chemical prophylaxis, and the outcomes of the study included VTE events and progression of hemorrhage, and they defined progression of hemorrhage as worsening CT findings. So the study found that patients who received pharmacologic prophylaxis had a lower incidence of developing VTE, and there was no difference found regarding progression of hemorrhage between the two groups. So the investigators utilized this protocol that I mentioned earlier that encouraged earlier chemical prophylaxis in patients with stable CT scans, and otherwise they would delay prophylaxis. So it's sort of unclear if this played a role in the progression of the hemorrhage outcome. It's possible that the trend that is seen is due to an avoidance of VTE prophylaxis in patients who were at a greater risk of hemorrhage. The protocol in place at this institution also did not include patients who underwent craniotomy, so that's important to consider. And the study showed that more patients who did undergo a craniotomy during the study period did not receive chemical prophylaxis compared to those who did. And the study doesn't talk about any other neurosurgical interventions other than craniotomy. So overall, this study did show that VTE prophylaxis is important to initiate if determined safe in patients with a traumatic brain injury, and the study concludes that although it's safe, this is a retrospective study design and the nature of the institution protocol, it is necessary to review further literature. The study also doesn't answer the question regarding patients who have received a neurosurgical intervention and then the optimal timing of initiating VTE prophylaxis. So that leads me to another study that occurred a few years later by Byrne and colleagues, and this was a retrospective cohort study that compared the effectiveness of early and late VTE prophylaxis in patients with a severe TBI. And then, just for reference, the investigators defined early prophylaxis as less than 72 hours and late prophylaxis as greater than 72 hours after their initial presentation to the hospital. Their primary outcome was incidence of VTE, and their secondary outcomes were late surgical intervention, defined as either a craniotomy, craniectomy, or intracranial monitor drain insertion that occurred greater than 72 hours after their hospitalization. And they also looked at in-hospital death. They did exclude patients who survived less than 5 days from presentation, and they found that early prophylaxis was associated with less incidence of PE and DVT, and there was not any difference found between groups for late surgical intervention or mortality. The authors found that there was more likely to receive late prophylaxis if they had a higher head injury severity, had presence of intracranial hemorrhage, or received early neurosurgery. And so this study did show that there is a decrease in odds of VTE in patients who receive pharmacologic prophylaxis within the first 72 hours of presentation. There was not a difference shown in regard to late surgical intervention. So this may indicate that the patients included did not have any adverse outcomes of earlier initiation. But this is a surrogate marker, so it cannot support causality. and there was not any difference found in mortality within the study as well. The authors did note that their mortality rate, though, overall was lower than other studies that have been done, but this was probably due to their exclusion criteria that I mentioned earlier of excluding patients who survived less than 5 days. So this study does begin to address some of our questions about timing of VTE prophylaxis in these patients with severe TBI who may be undergoing neurosurgical intervention, but it still doesn't answer the question that we have asked today. So I want to briefly touch on some different guideline recommendations who comment on patients who have an intracranial hemorrhage, and they comment on this in terms of either a traumatic mechanism or other mechanisms. So I'll start with the Brain Trauma Foundation that states that pharmacologic prophylaxis may be considered in addition to compression stockings if it is determined that the brain injury has stabilized. They do state that there is an increased risk of expansion of intracranial hemorrhage, but they're unable to make any recommendation regarding the agent to be used, dosing, or the timing of initiation of pharmacologic prophylaxis after the injury. The Neurocritical Care Society recommends that mechanical prophylaxis may be initiated within 24 hours of presentation or 24 hours after craniotomy. And then in terms of pharmacologic prophylaxis, they recommend that low molecular weight heparin or unfractioned heparin may be initiated between 24 to 48 hours after presentation or 24 hours after craniotomy. And then also the Eastern Association for the Surgery of Trauma, or you may see it as EAST, published some best practices regarding patients with TBI, and they've recommended that VTE pharmacologic prophylaxis is considered within the first 72 hours following TBI, and they also recommend to consider initiating pharmacologic prophylaxis even earlier than 72 hours if a patient is at a lower risk of expansion of intracranial hemorrhage and they have stable CT head scans. But as you can see, these guidelines don't exactly provide us exact timing with this patient population regarding severe TBI after a neurosurgical intervention. Which leads us to the study that I'm going to focus the remainder of my time on today. So this was recently published in JAMA Surgery. Byrne and colleagues investigated the association of venous thromboembolism prophylaxis after neurosurgical intervention for traumatic brain injury with thromboembolic complications, repeated neurosurgery, and mortality. This study was a retrospective cohort study that included patients who were treated at a level 1 and 2 trauma centers that were participating TQIP. For reference, TQIP stands for Trauma Quality Improvement Program, and this is an organization that collects data from over 800 trauma centers in the United States. The study period was included patients between January of 2012 through December of 2016. So participants were included in this study if they were greater than 16 years of age and had a blunt, isolated traumatic brain injury. The patients also must have required an urgent neurosurgical intervention, so this could include craniotomy, craniectomy, intracranial monitor or drain insertion, or both within 24 hours of their arrival to the hospital. And then patients also must have received pharmacologic VTE prophylaxis within their hospitalization to be included. As far as exclusion criteria goes, trauma centers who did not gather VTE data during this time period were excluded for the years that they did not collect data. And then if a trauma center was missing more than 25% of their VTE prophylaxis data, they were also excluded. Patients who were deceased or discharged before 5 days were excluded to avoid any competing risks. And then patients were also excluded from the study if they had a bleeding disorder or required chronic anticoagulation. So as far as outcomes go, the primary outcome of the study was the occurrence of VTE. And this was defined by the investigators as either a deep vein thrombosis or pulmonary embolism. And then secondary outcomes included repeated neurosurgery or in-hospital death. I do want to further explain some of these definitions that the investigators used to help you understand the outcomes when I go into the results. So repeated neurosurgery was defined as a repeated craniotomy or craniectomy or intracranial monitor or drain insertion after initiation of VTE prophylaxis. So the TQIP data set is unable to capture CT findings or acute neurologic changes in their data set. So the investigators determined that the repeated neurosurgery and in-hospital death could serve as surrogate markers for a clinically significant expansion of intracranial hemorrhage. Another definition is exposure, which was defined as the timing of VTE prophylaxis initiation after urgent neurosurgical intervention occurred. And then prophylaxis delay was defined as the number of days that elapsed between urgent neurosurgical intervention and their first dose of pharmacologic VTE prophylaxis. So, for example, if the patient received pharmacologic prophylaxis within the first 24 hours, then this was considered a delay of 0 days. And if a patient received pharmacologic prophylaxis between 24 and 48 hours, this was considered a delay of 1 day, and so on. This measure was collected for all of the patients included in the study to help determine the relationship between how many days after neurosurgical intervention VTE prophylaxis was initiated and compare that to the study outcomes of VTE, repeated neurosurgery, and in-hospital death. So the investigators took a unique approach to their statistical analysis. So I'm going to go through how they broke down their analysis into the patient level and then also the hospital level. So I'll start here with the patient level. The authors did plot the probabilities of the primary and secondary outcomes as a function of prophylaxis delay, which I defined on the previous slide. They then utilized hierarchical logistical regression models to estimate the association between prophylaxis delay and their outcomes. As part of these analyses, the authors also considered a large range of possible confounding variables, such as patient baseline demographics or their injury characteristics, and they did include these in their models if they accounted for a 10% change in their estimate or if the investigators deemed they were clinically important. This was important because we know that with an observational study, confounding variables are a particular concern, so they did a good job to include these in their analysis. So to move on to the hospital level, the authors divided the trauma centers included in their analysis into quartiles, and these were determined based on the percentage of patients who received early VTE prophylaxis. So this was, again, defined as a prophylaxis pharmacologic therapy that was administered within 3 days of their urgent neurosurgical intervention. Once they determined the hospitals in each quartile, they did perform hierarchical logistic regression models to evaluate the relationship between the quartile level and then the primary and secondary outcomes. And then finally, the authors wanted to see if they could directly measure the extent to which hospital practices for VTE prophylaxis timing accounted for the differences that were found in the study outcomes. So for baseline demographics, there were about 4,900 patients who were included in the study at 304 trauma centers, and the average age of the patients was about 50 years old, and the majority of patients were male. Falls was the most common cause of injury, and patients included in the study had a median head AIS score of 5, and just for reference, the AIS score goes from 1 to 6, with 1 being a minor injury and 6 being an unsurvivable injury. Intracranial hemorrhage was present in the majority of patients, and the median GCS of the patients was 7. And then, as you all recall, an inclusion criteria was neurologic intervention. So you can see that about 45% of patients had a craniotomy or craniectomy, 34% had an intracranial monitor or drain insertion, and 21% had both. And the median prophylaxis delay for the patients included in this study was about 3 days. So I'm going to go through the outcomes first at the patient level, and then I'll go to the hospital level. So starting with the patient level, the figures here shown display the probabilities of both VTE and repeated neurosurgery as a function of days of prophylaxis delay. So we'll start with the figure here on the left. You can see that the longer prophylaxis delay was associated with an increased probability of VTE. The logistic regression analysis revealed each additional day of prophylaxis delay was associated with an 8% increase in the odds of VTE. And so if you look on this graph here on the left, you can see that each additional day of prophylaxis delay, the slope of the graph gradually increases about 8%. In the the figure on the right, you can see the prophylaxis delay was associated with a decrease in the odds of repeated neurosurgery. So they also completed a regression analysis here, which revealed that each additional prophylaxis delay corresponded to a 28% decrease in the odds of repeated neurosurgery within those first 3 days. And then beyond that, each additional day of prophylaxis delay corresponded to an additional 15% decrease in the odds of repeated neurosurgery. So you can see that in these first 3 days, the slope of the graph is much more steep until at about day 3, and then the slope decreases more gradually. I do want to also note there was a significant interaction effect between prophylaxis delay and the type of neurosurgical procedure with respect to mortality. So those patients who underwent intracranial monitor or drain insertion were significantly more likely to die when administered early prophylaxis than those patients who underwent a craniotomy or craniectomy. And so each additional day of prophylaxis delay in patients who did receive an intracranial monitor or drain procedure was associated with a 6% decrease in their odds of death. So I'll move on to the hospital level. So this figure here shows how the investigators divided the hospitals participating in the study into 4 different quartiles, and this was based on the percentage of patients who were administered early prophylaxis, which was defined as prophylaxis within 3 days of surgical intervention. Results at the hospital level show that earlier prophylaxis was not associated with rates of VTE, and this was in contrast to the findings of the study at the patient level. However, hospitals in quartile 1 were associated with higher odds of repeated neurosurgical intervention than those hospitals in quartile 4, which indicates an association between early prophylaxis and bleeding risk similar to those that we saw at the patient level. The authors also calculated the proportional change in variance, or PCV, in order to measure the direct impact of hospital policy on the study outcomes of interest. So the PCV is a value that measures the differences between hospitals and the study outcomes that could be explained by early prophylaxis use while minimizing any confounds that may have been found at the patient level. So the authors found that 57% of the observed differences between hospitals in repeated neurosurgery were due to hospital practices, or in other words, the hospital-specific tendencies towards early prophylaxis use regardless of patient variables. In contrast, hospital practices regarding early prophylaxis use only accounted for 1.5% of the observed differences in VTE between hospitals. So Byrne and colleagues showed that delaying VTE prophylaxis led to an increased risk of VTE. However, earlier prophylaxis use was associated with an increased risk of repeated neurosurgery. The trauma centers with the highest tendency to initiate early prophylaxis had greater risk of repeated neurosurgery, and this led the investigators to hypothesize that trauma centers with protocolized approaches may enhance the risk of expansion of bleeds. The investigators discussed that the increase in risk of repeated neurosurgery did appear to be the greatest within the first 3 days of neurosurgical intervention, and this was a similar finding to the previous Byrne trial that I presented earlier during this presentation. So the authors concluded that VTE prophylaxis should be a priority in patients with severe TBI who undergo neurosurgical intervention, but it should be done with caution within the first 3 days after index procedure due to a concern of intracranial hemorrhage expansion. This study was very large, and the data was collected from many different trauma centers throughout the United States. And they did take a unique approach to analyzing their data and looked at the pharmacologic practice at both the patient level and the hospital level. So this would allow the readers to consider how different institution protocols may impact the overall results. The authors also took into consideration any potential confounding variables, but one thing that was interesting is that they did not disclose which confounding variables were adjusted for in their analysis. One of the largest limitations of the study was the utilization of ICD codes of repeated neurosurgery as a surrogate marker for expansion of intracranial hemorrhage, and there may have been other implications for these procedures that did not involve expansion of bleed or were related to the utilization of VTE pharmacologic prophylaxis. The study excluded patients who were deceased or discharged within 5 days, and this exclusion criteria was done to remove a potential confounding variable, but we have to consider there there is the potential for missing data here. So we may be unable to apply the results of this study to populations that may be deceased or discharged from the hospital shortly after their initial injury within those first 5 days. The authors also conclude that hospital protocols may play a role in the outcomes of interest in this study. However, it's unclear how many of these 304 institutions that were included have protocols in place for VTE prophylaxis in this patient population. And I know it may not be reasonable to include all of the specific institution protocols into a study, but it would be informative to assess the hospital level outcomes based on which hospitals have protocols in place and which ones do not. There's also likely institution-specific differences that may occur when within the included hospitals. For example, some institutions may have a lower threshold to repeat neurosurgical interventions compared to others. And then finally, this study was an observational study, so causation cannot be inferred. So finally, some of my takeaway points from the literature I presented today include VTE prophylaxis should be initiated once it's safe from a neurosurgical perspective, and there is literature that has shown that early pharmacologic prophylaxis can decrease the incidence of VTE. However, there may be an increased risk of bleed or necessary repeated neurosurgical intervention, so patient-specific factors should be considered when determining timing of initiation. And this study showed that hospital practices may have a greater role in patient outcomes, which should be investigated at an institution level to determine the safety of a protocolized approach if an institution decides to go that route. And due to the complexity and differences between patients, hospital protocols that emphasize early prophylaxis amongst all patients may negatively impact the population of patients, so it's important to take that into consideration when developing a protocol. It may be reasonable to consider 72 hours as an appropriate time to initiate VTE prophylaxis in patients who do have a stable bleed after neurosurgical intervention. However, future prospective studies are needed to determine risk factors for ICH progression, and cost and ability to transport patients may be limiting factors, but it would be ideal to design a study that assesses utilizing repeat CT scans to help determine the safety of initiation of VTE prophylaxis. And with that, I will take any questions. I see there may be some in the chat, potentially.
Awesome. Thank you so much, Jessica. That was a great presentation on, I think, a really good topic that probably all of us deal with and don't have the best evidence to turn to when it does come up. So I think this is a really great journal club. I'll read out this one question we have in the chat, and then anyone else can feel free to enter more questions in the chat, or feel free to unmute yourself and ask it out loud. So we have a question here. How do you interpret the interaction the authors found with earlier prophylaxis and increased mortality after EVD placement? Does this finding influence your thoughts on 24-hour start versus 48 hours?
So I did think that this finding was interesting as well, that it was only found when they looked at, when they separated out the different types of neurosurgical intervention, and they looked at the interaction effect with either craniotomy or craniotomy, or an intracranial drain or insertion, and they only found the increased mortality with the EVD placement. I'm not quite sure exactly why they found this in one group and not the other, but as far as why that would influence my thoughts on 24 hours versus a start versus 48 hours, I actually think that in this patient population, it may be more appropriate to utilize like repeat CT scans to help determine the stability of a patient's bleed, regardless of if it was due to a craniotomy or due to a drain insertion. The authors don't really go into why they think that this difference happened as well. It may be due to it may be due to differences in the type of like surgical, like maybe patients who have had an EVD place may become less hypercoagulable compared to patients who had a craniotomy or craniectomy. It may come down to like the type of surgical intervention in those terms. But I do think that in these patients, kind of like how I concluded at the end, I do think that just blindly deciding may not be the best decision, since there was these interaction effects, not just here, but also at the hospital level. And so it may be better to try to utilize CT scans to help determine the safety implications of starting DVT prophylaxis.
Oh, I was muted there. Thank you for the response. Thank you for the question as well. We're just about at time. I'll ask one more quick question. Did they account for blood pressure at all for these patients in the regression model? Because certainly a patient with uncontrolled blood pressure could certainly be a reason for an easy and common, I think, reason for hematoma expansion that may necessitate the patient to go back in for surgery. So did they discuss that that was included in the regression model?
So they did not, so in their supplementary, they do go through their different regression pieces. So they included different disease states, whether they use unfractioned heparin or low molecular weight heparin. They included gender and things like that. I'm trying to think if they did include blood pressure. I don't recall reading that. They did not comment on what they included in the actual text of the article. However, in the supplementary, they did break down for each level of what they included. And I don't recall them talking about blood pressure management or patients' blood pressures prior to initiation.
Got it. Yeah, that would be interesting to know. Okay, excellent. Thank you so much, Jessica. If you don't mind stopping your share screen, I'm going to allow Megan to share her presentation. And as she pulls that up, I'll go ahead and introduce her. We do have another question that was in the chat. I think there's a lot of good discussion going on Twitter, as well as the chat here. So feel free to, Jessica, respond to the question in the chat there. And if you have a Twitter, perhaps you can pop on and see if there's anyone with any discussion points or questions. Okay, awesome. So our second speaker is Megan Taylor. Megan is a PGY2 critical care resident at UNC Rex Healthcare. Her journal article is going to be on alteplase administration in acute ischemic stroke following recent oral anticoagulant use. As a reminder, please mute your mic if you are not presenting. Okay, all yours, Megan.
Awesome. Thank you for that introduction. Can you hear me?
Yep.
Okay, perfect. Sorry, I'm trying. Okay, there we go. And before we get started, just some objectives for today are to review the acute ischemic stroke management and treatment options, as well as evaluate emerging literature surrounding thrombolytic therapy in patients with the recent NOAC use. And for your reference, I've just included abbreviations that will be discussed throughout the presentation today. I did want to make a note that I will be referring to oral anticoagulants as NOACs. I realize this abbreviation has fallen out of favor, but that is the way that it is presented in the study that we'll be talking about. So I just want to let everyone know that I will be referring to those NOACs today. Briefly, just to give you a little background on stroke. So more than 795,000 Americans suffer from a stroke each year, and the majority of those, around 87%, are of the ischemic pathology. So with these strokes, they typically result from a clot or a plaque that obstructs cerebral blood flow, and some of the most common causes being atrial fibrillation, hypertension, and atherosclerosis. Moving into our one and only FDA-approved treatment option currently, which is alteplase, also FDA indicated for the treatment of PE and STEMI. Alteplase works by binding to fibrin in the clot and converting entrapped plasminogen to plasmin, which essentially acts as a clot buster. Its onset is within minutes, and some of the complications that we typically have to monitor for are intracranial hemorrhage and angioedema. So who is alteplase indicated for? And I think the 2019 AHA stroke guidelines do a really great job breaking down who exactly qualifies for therapy and who would be contraindicated. So with alteplase, we have to make sure that patients present with a mild but disabling stroke within the last 3 to 4.5 hours of their last known normal. And we have to have CT evidence ruling out any hemorrhage or any kind of bleeding. These patients also have to be ruled out for hypoglycemia, and we also want to make sure their blood pressure is appropriately controlled before we can initiate alteplase therapy. The guidelines also do a really great job discussing major contraindications as well as some relative contraindications to thrombolytic therapy. I've included some of the most pertinent here for our discussion today, but I really want to focus on the last one, which is NOAC use within 48 hours. The guidelines don't provide clear guidance exactly on these. They essentially mention that we shouldn't be using alteplase therapy in patients if they've used a NOAC within 48 hours, although it can be considered if their coagulation tests are normal. And I think this brings a great segue to our topic today, because as atrial fibrillation is one of the #1 causes of stroke in the United States, more and more of these patients are anticoagulated, and it leaves providers with a clinical decision to make and a lot of gray area to decide. And so it really comes down to a risk-benefit decision. If you recall from the earlier landmark trials, the NINS and the ECAS studies, you'll remember that alteplase really actually has no mortality benefit. So patients who are treated with alteplase versus placebo, there was no difference in mortality, and there actually was a risk of symptomatic intracranial hemorrhage. So studies since the NINS and ECAS have estimated risks of intracranial hemorrhage up to 7% in patients who receive thrombolytic therapy versus those who don't. And so that may also lead you wondering why we would use alteplase if there is a risk of hemorrhage. And those earlier studies also found, despite there not being a mortality benefit, there really is a clear improvement in functional status. So patients who are treated with thrombolytic therapy are 30% more likely to have minimal or no disability at 90 days. So it truly is a risk-benefit decision for providers. And then briefly, before we move into my study, I just want to highlight some of the literature surrounding thrombolytic therapy in patients with recent anticoagulation, as this is still a major gray area in the guidelines. As you'll see, the 3 studies that I looked at and are highlighted today are all observational studies, so we don't really have strong evidence for or against thrombolytic therapy in these patients. The first study was an observational cohort study of about 9,500 patients who had an acute ischemic stroke treated with IV thrombolytics or intra-arterial thrombolytics. Their primary outcome was intracranial hemorrhage or death within 3 months. And you'll see with the NOAC and warfarin group versus the non-anticoagulated group, there was no significant difference in that primary outcome of intracranial hemorrhage or death. The second study was also observational, but a much smaller size of 100 patients. Again, they wanted to look at patients recently anticoagulated, receiving either IV thrombolytics or endovascular therapy. Their primary outcome was intracranial hemorrhage within 24 hours. And again, looking at the NOAC, warfarin group, and non-anticoagulated group, there was no statistical significance in risk of intracranial hemorrhage within the first 24 hours. The final study was again observational in design, but it was much larger at 43,000 patients. Again, these patients were acute ischemic stroke patients treated with IV thrombolytic therapy. And this study looked at the occurrence of intracranial hemorrhage, overall hemorrhage, and then any alteplase related complications. And you'll see in looking at patients on NOAC therapy, warfarin, and then the non-anticoagulated groups, there was no significant differences in risk of intracranial hemorrhage, overall hemorrhage, or any alteplase related complications. And so again, this really just leaves providers with a lot of gray area and uncertainty on whether we should be using thrombolytics or whether it's truly safe. And that leads me to our study today. So the clinical question is recent NOAC use associated with increased risk of intracranial hemorrhage in patients receiving IV alteplase for acute ischemic stroke? And then here is the study and the authors. This was the association of recent use of non-vitamin K antagonist oral anticoagulants with intracranial hemorrhage among patients with acute ischemic stroke treated with alteplase by CAM and their colleagues. And this was published in JAMA in earlier this year. The objective of the study was to determine the safety and functional outcomes of alteplase therapy in patients taking NOAC prior to stroke compared with patients not taking anticoagulants. This was a retrospective analysis of two related national acute ischemic stroke registries, and the data was collected from April of 2015 to March of 2020. And I just briefly wanted to talk about the two registries because they are a little bit different, but essentially the same population of patients. So the first was the Get With The Guidelines Stroke Registry, and this is an all-encompassing registry that includes not only demographic information, but specific information about the stroke type and really everything that occurred from admission to discharge for each patient. So all of their imaging, if they received thrombolytic therapy, any complications they may have had, and then what their dispo was. So whether they went home, went hospice, or expired. The ARAMIS registry sought to build upon the Get With The Guidelines Stroke Registry. So it essentially looked at the same patient populations, but it had very specific information about their oral anticoagulation. So from this registry data, they were able to pull when patients last took their anticoagulant prior to receiving thrombolytic therapy. Moving to the eligibility criteria, so patients had to have an acute ischemic stroke treated with IV alteplase with half hours of symptom onset. And again, this data was collected from April 2015 to March of 2020. So their data had to be in one of those registries from that time period. They also, patients did not have to be taking anticoagulation, but if they were, they had to have a documented dose within the last 7 days of thrombolytic therapy. And I think this is a really important point to make as we go through the results of this study, as again, the guidelines really, that gray area is within less than 48 hours. So just something to keep in mind as we continue throughout the discussion today. As far as exclusion criteria, patients who were taking warfarin or any other non-NOAC anticoagulants, or if they were taking multiple anticoagulants, were ineligible to participate in this study. If they received alteplase outside of the standard stroke guidelines, if they had an in-hospital stroke or received alteplase at an outside hospital, and then if they were transferred to another hospital or missing any discharge information, they were not eligible to be included in this study. The primary outcome of the study was symptomatic intracranial hemorrhage within 36 hours of alteplase administration. And then secondary outcomes were broken into safety outcomes as well as functional outcomes. So the safety outcomes was inpatient mortality, life-threatening or serious hemorrhage within 36 hours, any alteplase related complication, and then a composite of in-hospital mortality or discharge to hospice. In terms of functional outcomes, the study assessed independent ambulation at discharge, patients who are free of disabilities, and then functionally independent at discharge as well. And then briefly to provide you with the information on the statistical method. So a propensity matched multivariate logistic regression model was created to assess anticoagulant status and their in-hospital outcomes following thrombolytic therapy. They did use weighted propensity scores that were computed to control for differences in baseline characteristics, clinical outcomes, and hospital factors. And then data was reported as adjusted odds ratios and risk differences computed from that regression model. P-values were two-sided, and any values less than 0.05 were deemed statistically significant. Moving into the results, so there were just over 163,000 patients that met criteria for this study, the majority of which were in the non-NOAC group at 160,000 patients, and just over 2,200 patients were in the NOAC group. Just to orient you a little to this slide, so this study did compute absolute differences for each of the groups to determine if there was any meaningful imbalances between them at baseline. And I've highlighted the ones that were considered meaningfully different. So any value above 25 was considered a meaningful imbalance. Looking at their baseline characteristics, you'll see the majority of patients were men in their low to mid 70s. You'll see in the NOAC group, the majority of patients did have a history of AFib, which is what we would expect. And then their NIHSS median score was anywhere from 7 to 10, so really in that moderate stroke range. The study also reported thrombolytic and hospital characteristics. You'll see the onset to needle of thrombolytic therapy was just around 2 hours for both groups. And then the door to needle time was right at a little under an hour for each group. Each of the stroke centers had an annual acute ischemic stroke volume of around 350, and you'll see the majority of stroke centers were primary stroke centers. Moving into the primary outcome, which again was occurrence of symptomatic intracranial hemorrhage, you'll see there was no statistically significant difference between the NOAC group and the non-NOAC group in the occurrence of symptomatic intracranial hemorrhage. So there was about 3.7% that experienced a intracranial hemorrhage in the NOAC group compared with 3.2% in the non-NOAC group. And I've reported the unadjusted odds ratios that were calculated, which were not statistically significant, as well as the adjusted, which continued to be not statistically significant between the groups. So overall, there was no significant difference in the occurrence of symptomatic intracranial hemorrhage. Moving into the secondary safety outcomes, I've listed the outcomes on the left for you, and I've tried to highlight some of the key data. So in terms of inpatient mortality, you'll see there was significantly more mortality in the NOAC group at 6.3% versus 4.9% in the non-NOAC group. This was only at in their unadjusted analyses. So once they adjusted for differences in baseline characteristics and demographics, this actually was not statistically significant, and they found no difference between the groups in inpatient mortality. Looking at life-threatening or serious hemorrhage within 36 hours, as well as any alteplase related complication, you'll see there's no statistically significant differences between the groups. And then the composite of in-hospital mortality or discharge to hospice, again, was statistically significantly higher in the NOAC group at 12.4% versus the non-anticoagulated group at 9.4%. Again, this was only in the unadjusted analysis. Once they adjusted again for those baseline characteristics and differences, this was found to be not statistically significant. And then looking at secondary functional outcomes, again, whether patients were able to ambulate independently, which was defined as an MRS score of 0 to 1, if they were free of disabilities, and then functionally independent. So you'll see initially, and it looks like the data favors the non-NOAC groups in the unadjusted analyses, but once they were adjusted again for baseline differences, you'll see it actually favored the NOAC group. So patients in the NOAC group were more likely to ambulate independently, free of disabilities, and also to be functionally independent at discharge once those adjustments were made for baseline differences. And then the ARAMIS registry outcomes, which again was the more specific data on the last time the patients took their anticoagulant. Unfortunately, only 47 patients were included in this trial based on the available data at that time. So we don't have a whole lot of data from that registry, but it does provide some meaningful information. So you'll see of the 47 patients, 2 or 4.3% of them experienced a symptomatic intracranial hemorrhage within 36 hours. And those were within, or those were patients who last took their anticoagulant less than 48 hours from onset of their stroke. You also see, looking at their mortality and severe complications, there is no instances of life-threatening hemorrhage that were reported in any of the patients with the ARAMIS registry outcomes. So the authors concluded that recent use of NOACs within the 7 days, as that's what they were able to capture of an acute ischemic stroke event treated with IV thrombolytic therapy, was not associated with an increased risk of intracranial hemorrhage. And just assessing the trial myself and kind of building off of what the authors concluded, there were several strengths of this trial. They did have a large sample size of 163,000 patients, and it was real world data. So it was built off of those registry outcomes. And it was, again, a large sample size. And they did try to seek to answer a clinical need. Again, there's still a lot of gray area about the appropriateness of using thrombolytic therapy in patients who are recently anticoagulated, and we just don't have a lot of literature to support for or against that. So it was a clinically meaningful study. And I believe the authors really sought to use appropriate statistical methods to try to adjust for confounders and try to present the data as best possible and to control for those possibilities. But like any trial, it wasn't without weaknesses or limitations. So obviously the observational study design and hypothesis generating in nature and is hard to draw firm conclusions from. There's a limited NOAC sample size. So again, out of the 163,000 patients that were included, only 2,200 were on anticoagulants. And then the Aramis registry only captured 47 patients. So it's really difficult to actually assess if it's truly safe to use thrombolytic therapy in patients recently anticoagulated. There's also the possibility of selection bias. So from both registries, there are about 23,000 patients who were anticoagulated who did not receive thrombolytic therapy, which lends to that the 2,200 patients that were included were likely healthier and less at risk of having a bleed, and the providers deemed it appropriate to use thrombolytic therapy in those patients. Again, with the trial design and limitations, this limited internal and external validity. And also the way the data was collected and through limitations in the registry, there was a lot of missing pertinent data with regard to anticoagulation labs. So were these patients fully anticoagulated, or were they not maybe taking their NOACs? We also don't have data on the dose of alteplase that they received, or if they ever received any reversal agents prior to receiving thrombolytic therapy. Because this was a registry study, there's really no long-term mortality data. So they were just assessing patients at the time that they were admitted into the hospital. And then differing stroke pathologies between the groups could also bias the results. So again, most of the patients in the NOAC group did have atrial fibrillation and had a cardioembolic stroke, versus the patients who were not anticoagulated likely had a different pathology for their stroke, which could have differed in how their risk of intracranial hemorrhage. And then also, as I mentioned in the baseline characteristics, most of the patients had mild to moderate stroke, which really puts them already at less of a risk of experiencing an intracranial hemorrhage. So my personal takeaway from this study is that currently there's still not enough data to routinely recommend thrombolytic therapy in of acute ischemic stroke and recent anticoagulant use. When stratified by NOAC timing, the intracranial hemorrhage rates were actually about 8% in patients who took their NOAC, and that's from the Aramis registry. If they took their NOAC within 48 hours versus the 3.2% of patients not on anticoagulation. So that could have been underrepresented. The study also had extensive limitations, which limits the understanding of the true safety and generalizability of the data. And the study even mentioned that patients who received alteplase while on anticoagulant therapy happened to be younger, had fewer comorbid conditions, and severe strokes, which could alter how we interpret this data. So how do we apply this to practice? There's still significant debate regarding the use of thrombolytic therapy with recent anticoagulant use. So really larger and more robust studies are needed to assess safety in that less than 48-hour window. That is still unclear based on guideline and evidence recommendations. So again, my takeaway is that there's not strong enough evidence to recommend for or against thrombolytic therapy with recent anticoagulation use. And that's again within the less than 48 hours. And at this time, I'll take any questions.
Awesome. Thanks so much, Megan, for presenting that very interesting study. Yeah, I mean, published in JAM, I believe, right? So it's certainly something that you could imagine coming up in real life, in this kind of acute situation. You often get a question, hey, this person is an alteplase candidate, but, they have a DOAC in the profile, like, what should we do? And it'll be interesting to see if, people may refer to this study. So I think having good knowledge of this study and some of the limitations are probably a good thing. So we have some questions flowing in the chat. So let's see. Did the authors do any subgroup analysis of bleed risk comparing one DOAC to another, i.e. dabigatran versus apixaban or versus rivaroxaban, et cetera?
No, that's a good question. I think that would be really interesting to see. As we know, typically rivaroxaban and apixaban have less of a bleeding risk. Unfortunately, they didn't report even what percentage of patients were taking which anticoagulant. I looked in the supplementary, I couldn't find that information. So unfortunately, there was no comparisons, but I think that would definitely be interesting to look at for future studies.
Awesome. Funny enough, we got the same question twice, so it is certainly a good question. One question I had is just, was there any like rationale or explanation from the authors on perhaps why some of the subgroups that they analyzed that were taking the DOACs actually did better than not being on a DOAC? Like some of the groups had lesser bleed risk if they're on a DOAC before. Some of the outcomes seemed to be favored towards them. Was there like any rationale or plausibility that like this is an actual like finding from the authors, or just by chance?
Yeah, I feel like they tried to justify that by mentioning that there were actually 23,000 patients in both of the registries that were taking anticoagulants and they didn't receive thrombolytic therapy. So it might have been more of like a selection bias. And they did mention that the patients who received thrombolytic therapy on NOACs were typically younger, had less comorbid conditions, and typically more severe strokes. So it seemed like they were trying to suggest that it probably could have been some selection bias. Most of those patients might have been, a little healthier and less risk of having an intracranial hemorrhage.
Yeah, good points. Another question in the chat here. Does your center have the ability to check DOAC specific anti-10A levels?
We do monitor anti-10A, but it's actually, we look at it for our heparin dosing, so I don't think that it's actually correlated to our DOAC anticoagulants.
Yeah, I wonder if, and if anyone on the chat in the presentation like actually does this with like spot level testing that comes back rapidly, I'd be curious to personally know myself. It could be used, I guess, in this situation, perhaps like ICH related reasons as well. But maybe that would be a bit of a more objective way to know whether or not, because most times you probably don't know whether or not they took their last dose recently. That might be a bit of a more objective way to know that piece of information.
Yeah, that's a really good point. Sorry, go ahead.
Yeah. One more question I had was there any rationale explanation from the authors also in regards to the 7 days that they looked at? Was that just how the registry is like logged? Why did they use the 7 days?
Yeah, I was wondering the same thing. And from what I could find, that's the way it's documented in the registry, which is really unfortunate. And that's why I think they were trying to pair the Aramis registry and hopeful that that would give them more information, since it does tell them more about the timing. But even then, only 37 patients fell into that Aramis registry. So I think it was a fault of what data they could get from that registry. But at the end of the day, it didn't really give us a clear answer, which is unfortunate.
Got it. Thank you. Looks like we also have some clarification. That is how the Get With The Guidelines data works. Okay, so there you go. It would have been really exciting if the Aramis registry had like, the full number of patients confirmed with their doses, right? That probably would give us a lot of information as opposed to that very small percentage.
For sure.
Yeah. Excellent. Okay, looks like there's no more questions. Well, thank you so much for the presentation, Megan. And thank you so much for the presentation earlier, Jessica. There are lots of great discussions going on Twitter. My phone is definitely blowing up right now with a lot of vibrations. I'm getting tagged on Twitter a lot. So be sure to go on Twitter using the hashtag NCSPharmJC to jump on board and have these discussions. The postings for these journal clubs are posted on YouTube. So probably maybe in a month or so. So be on the lookout for that. Thanks so much for everyone for joining today and participating. Look forward to seeing you all next time. Take care.